Good morning. Thank you for the introduction, sir. So I'm Jasmine Scott. I'm the resident that's on the service. I'm going to be presenting on herniated nucleus pulposus. Cameron Shirazi, the prior fellow, gave this talk last year. It was very good, had a lot of different studies in it. So I felt like that was great from the fellow's perspective. I'm going to try to do it more on the resident perspective. So a little bit more of the foundational knowledge to hopefully help any of the residents that are coming on service after me, and will be a nice review for everyone else here today. So it's just an outline. We're going to do anatomy, epidemiology workup, leaning heavily on those NAS guidelines, op versus non-op, and outcomes. All right, so first, just starting with the anatomy, you have the intervertebral disc, which has an end plate, the annulus, the nucleus pulposus. Annulus is mainly that type 1 collagen concentric lamellar rings. Tensile properties contain the nucleus against compression. And then we have the nucleus, which is mainly type 2 collagen, filled with elastin proteoglycans, sort of a higher water concentration and more of a shock absorber, and transfers the forces are transferred to the annulus and the adjacent vertebra. This schematic I liked just in terms of showing where the innervation is. So the outermost layers of the annulus fibrosus innervated by the sinovertebral nerve. In terms of intervertebral disc degeneration, that can obviously be a whole separate talk unto itself. But the big takeaways that I saw were that there's decreased aggrecan, which also means that there's decreased water, increased cytokines and metal metalloproteinases, as well as TGF alpha, and then that increased keratin sulfate to chondroitin sulfate ratio. This is a schematic from this Joust article from Kepler et al. In 2011, kind of trying to explain the inflammation cycle that happens in degeneration, but basically the increase in the cyclooxygenase PGE2 IL-6, which is for this positive feedback loop or vicious cycle, which contributes to the degeneration. And the this one sort of not from that paper, but just in my head, it made more sense. It was a little easier for me to understand. I think I like the bright colors too. In terms of the etiology of pain, that's not entirely clear. There are some certain chemicals that are associated with it, substance P, nerve growth factor, brain derived growth factor. They've all been implicated, but not entirely clear. This next paper looked at the histology and pathology of the human intervertebral disc. So the big takeaway for me on this was talked about those increased cytokines and inflammatory mediators in herniated discs. So that is clear that there are more. So the TNF alpha interleukins, the MMPs, and then TSG is a precursor to TNF alpha. And additionally, I thought this was really interesting, and they show this histologically actually in this paper as well, but there's increased innervation in degenerated discs. So there's actually more nerves present as the disc degenerates, and a higher percent of senescent cells, so 8.5% in the degenerated disc versus 0.9% in the normal healthy discs. And then G and H are supposed to just be showing that, so H showing that there's more senescent cells. So one thing that I had a question about coming into this was what actually is a herniation? Like, what is the definition of it? I've seen a lot of different interchangeable terms, protrusion, disc bulge, herniation. So I found this paper as a combined task force, American Spine Society, American Society of Spine Radiology, and American Society of Neuroradiology from about 20 years ago. And they sought to define it specifically, which is localized or focal displacement of disc material beyond the limits of the intervertebral disc space. Table 2 down there shows different descriptors of disc herniation, and we'll talk about a couple of them, but the important thing to know is there's a lot of different ways to describe it. So morphology, containment, volume, composition, and location. And then here is just sort of an axial. This is a view of the subvertebra, and they talked about the central canal zone, also called posterolateral subarticular zone, foraminal zone and then extraforaminal zone. We'll talk about all of those with a little bit better pictures coming up. And then also just looking from the sagittal. So you can also define the location in relation to the pedicle. So above, well, at the pedicle, below the pedicle, and then at the disc level. This was a great resource that I found that helped me understand these locations a little bit better. So green is central, that yellow would be the subarticular or lateral recess. Orange would be foraminal, and then red would be that extraforaminal. And I thought this was really nice. So we can see here the central. So on the left is axial with the color coding, and then on the right is axial without any markings on it. And obviously the sagittal in the middle. Lateral recess here. Of course, central and subarticular or lateral recess are going to affect the transiting nerve root. And then we have foraminal here in orange, and then extraforaminal, which are going to affect that exiting nerve root. So in addition to the location, we can also talk about morphology. So this is a schematic, just A, B, C, and D. So A being a normal disc, B being that protrusion. So the nucleus is sort of pushing the annulus, which is compressing the root, but not sort of outside of the annulus, until we get to C, where you have extrusion, where that nucleus is sort of outside the boundaries of the annulus, and then sequestered, where the nucleus has come completely outside the annulus and is not connected anymore. And all of those can put pressure on the nerves. Then containment, so whether it's contained by the PLO, and then timing, acute versus chronic, it seems anywhere between 6 weeks to 3 months. Start thinking about it being a little bit more chronic. So this is a paper out of Rothman, Thomas Jefferson. So this is talking about epidemiology and pathophysiology of lumbar disc herniations. So when does a herniated nucleus puplosus occur? So essentially, when you have that degenerative process and that cellular senescence, loss of rigidity of the annulus, sort of talking about that feedback cycle that we looked at a couple of slides ago. And then also that soft discs, I'm sorry, here's the schematic here. So you can have a concentric annular tear or a full thickness annular tear that you can kind of see here how that happens visually. So soft discs more likely to herniate than older, more fibrotic discs. And in this paper, sort of a classic paper, looking at sort of epidemiology and presentation of cervical discs. The images on the right are from this original paper. So it talked about 3 different clinical presentations. So median causing that myelopathy or central cord, obviously the myelopathic symptoms being sort of that loss of hand dexterity, maybe some gait imbalances, and then that pathologic Hoffman's reflex. Perimedian causing more of that brown sequard with the contralateral motor, ipsilateral pain and temperature, and the lateral being radiculopathy, like we are sort of accustomed to seeing in the upper extremities. This paper sought to sort of quantify the incidence of cervical radiculopathy. It's out of Mayo from 1994, so classic paper. And they looked at the population study with 70,000 people with 561 cases of radiculopathy. They reported the incidence of 89 per 100,000. And then their paper, they noted 20% radiculopathy with HNP. I found a more recent paper. It was from the Army Institution in El Paso, Texas. And so one of the issues with the Mayo, or trying to study this in general, is just finding sort of a captured patient population. So this paper noted that the Defense Medical Database actually served as a great resource for that. And so they had 13 million patients at risk with a diagnosis of almost 25,000. And they're reporting a much higher incidence of cervical radiculopathy than the Mayo paper. And they also noted that this was consistent with a paper out of Sicily, which also found the incidence to be about 3.5 per 1,000. So one of the things that this paper talked about is, while the Defense Medical Database may not be completely accurate representation of the population of the United States as a whole, it certainly is far more racially diverse and socioeconomically diverse cohort than the 70,000 patients that live in Rochester, Minnesota. And just the number of patients studied is substantially higher. So rather than only having 561 cases of radiculopathy, they had almost 25,000 cases of radiculopathy. So just making the argument that maybe it's a little bit more prevalent, or the incidence is a little bit higher than we thought based on the Mayo paper. All right, so there's a lot of different studies on epidemiology of lumbar disc herniations, but they are extremely common. This is from the NAS guidelines, but basically over 3 million herniations in the United States per year. And then many of them are asymptomatic or require no treatment. And then just going back to the Vaccaro paper out of Rothman, just wanted to point out that those posterior lateral herniations are the most common, affecting the traversing nerve root. So at L4-5, it would be L5, L5S1 would be S1. And then the pain, again, we don't have like a great understanding of what causes the pain, but either mechanical compression or chemical irritation of the nerve root. There are many different articles that try to address this question, what specifically causes the pain. I didn't want to go through every single one of them because there's a lot, but people are investigating both the mechanical compression, the chemical mediators. They're looking at animal studies. This one was in rats. This one looking at nitric oxide, cyclooxygenase, just cytokines in general. And then this study was in dogs. I think my takeaway from this is that this is something that we're still seeking to understand better, and we need further research. All right. So transitioning to sort of the next part of the talk is, how do these patients present, and what is our workup going to be for them? So the North American Spine Society has sort of recommendations, evidentiary-based clinical guidelines for both the cervical spine, which you can see on the left, and the lumbar spine on the right. These are just intended to be guidelines and recommendations, and they're very specific in the sort of preamble to this, that they do not represent the standard of care, just supposed to be guidelines. All right, so for physical exam, which is where we normally start in our clinic visits, for the cervical spine, talked about how provocative tests, including the shoulder abduction and Sperling's test, just to kind of identify, is a cervical radiculopathy, or is there intrinsic shoulder pathology. So recommendation grade C on that in terms of helping tease out if it's cervical radiculopathy. And then for the lumbar spine, talking about the sort of importance of the straight leg raise, and they gave that a grade A recommendation. I think for me in practice, I definitely plan to do a very thorough physical exam. This was kind of a cool paper, a little bit older. So instead of using MRIs, they did use myelography, but essentially they were looking at the positive predictive value of physical exam, both for motor weakness and then also for sensation, and then just looking at the, and then confirming that based on herniation. So basically what this paper is showing is that there is good positive predictive value for actually doing an exam for both motor and sensory. And then again, per the NAS, at least for the lumbar spine. So sorry, that probably should be recommendation level A, that you should do. The motor testing can provide specific clues to the level of disc herniation. I think this is probably most relevant in situations where we don't yet have an MRI. All right, so then specifically when we're talking about exam for lumbar spine, is there a difference between the seated straight leg raise and the supine straight leg raise? And there is. This study found that the supine straight leg raise had higher sensitivity than seated. This was important for me because I've seen both in a clinic setting, and sometimes it's not always easy to just have the patient like lay down and do it, but after seeing this paper, I definitely will, just because that sensitivity is a little bit higher. And then the NAS addressed this specifically with a grade recommendation of B for doing supine versus seated straight leg raise. Okay, so the next thing is what type of imaging should we be looking at when we have these patients come in with either cervical or lumbar radiculopathy. This is a guidelines from the sort of the radiology world, so not from ortho specifically or neurosurgery spine. So this I was looking at, so this is new or increased non-traumatic cervical radiculopathy without any red flags. So in the C-spine, the recommendation is for an MRI without IV contrast, sort of more so than just getting a set of x-rays. And that's, again, just from a radiology perspective of what's going to expose the patient to the least amount of radiation, but also sort of diagnose the problem. So the MRI does that better than x-rays, but obviously we'll talk about when x-rays are important a little bit later in the talk. And then they have the same thing for low back pain. This was very interesting to me, but basically in someone sort of just with new or subacute chronic low back pain without radiculopathy, no red flags, they're saying that it's not appropriate to get sort of any imaging. I think that is fine. I don't know how that necessarily translates to being sort of like a specialist. Maybe this is more relevant for folks in like the urgent care setting, primary care. But if there is any radiculopathy, if they've been sort of dealing with it, it's changing, then imaging is, it says may be appropriate. Again, they're going to tend towards the MRI because there's less radiation. So just to recap, so advanced imaging, if there's radiculopathy and a clinical exam concerning for HNP, to get the MRI myelography if you can't. And then x-rays, definitely before surgery to assess for instability in both the lumbar and cervical spine. And I think just in general, having an understanding from the x-rays is very reasonable going forward when you're doing these workups.
I also don't think, at least in my experience, that insurances will approve the MRI without any
x-rays before.
X-ray.
Yeah, that's a good point.
It's different. Insurance by insurance, but that's kind of something for years that I'd like to do. So.
Oh, great. Thank you. All right. So how do we take care of these patients and help make them better? So we won't spend a ton of time on the non-op treatments for HNP. I will go through just quickly over some of the literature, but this is a study. This is actually from a pain journal. They systematic review, looked at a variety of different oral pain medications. And this is actually a quote from this paper. It says most of the pooled estimates did not favor the active treatment over placebo, sort of any of these oral medications, and low quality for the efficacy. So the NAS for physical therapy, NAS guidelines in terms of standalone physical therapy, cervical lumbar spine, insufficient evidence. This is a paper that looked at patients getting a selective nerve root block, did physical therapy, plus minus physical therapy, did it help? PT didn't seem to have any significant impact on the outcome. Epidural steroids, specifically for cervical HNP. The point of this study is they had a lot of different epidural injections, 192,000, 8-year follow-up. Primary endpoint was surgery. So you can see there the percent that ended up getting these injections. So the bottom line takeaway is by 5 years, 20% of these patients are still going to be undergoing surgery. And then ESI or transforaminal ESIs for the lumbar spine. They were sort of looking at just transforaminal epidural steroids plus local alone, saline, IM steroid, and IM saline. And the takeaway from this paper was that the transforaminal epidural steroid and local had better pain relief than the other treatment. but that was only at 1 month. And then they noted that 36 of the patients who did undergo the ESI ended up eventually getting surgery within 12 months after the injection. All right, this paper just shows that there is spontaneous regression of lumbar herniated discs. This was a systematic review, 31 studies. They found the rate of spontaneous regression, 96 for disc sequestration, 70 for extrusion, 41% for protrusion, and 13% for disc bulging. And the rate of complete resolution of the herniated disc was 43% for sequestrated and 15 for extruded. So again, just to keep in mind, the natural history of these is many of them will resolve.
Is there hydration? They're like attachments, though. The sequestered one.
Oh, and that's why they resolve. Oh, interesting. Yeah, I noted that was much higher than the other ones. Rather than just sort of like screenshotting all the different NAS guidelines, this is just a quick summary of it. But suffice it to say, injections, physical therapy, oral pain medications, it's basically all inconclusive evidence that they completely resolve the issue. Physical exam and imaging get level A, and then sort of just medical management of these problems, level B. All right, so this is just summarizing the non-op highlights, kind of what we just talked about. I think the bottom line takeaway from this is natural history of these is that they resolve. There's not a strong amount of evidence supporting utility physical therapy. However, it does, patients that want to go to physical therapy probably should. It gives them sort of something to do. Epidural steroid injections may help sort of more in the short term, but definitely don't resolve the underlying pathology. And so there's no definitive evidence that these non-surgical treatments alter the natural course of the disease. All right, so when do we definitely do surgery in these? So the list of absolute surgical indications isn't very long. So that progressive worsening neurologic deficit, and then for the lumbar cauda-equina syndrome. I think in general, what I've seen relatively is that if someone's having persistent debilitating pain greater than 6 weeks without improvement, then generally they are offered surgery. And obviously, patient decision-making is very large in this. So this, one of the other things I've seen that in the clinic when we tend to sort of suggest surgery a little bit more stronger to patients is there like a motor weakness? Obviously the foot drop or that dorsiflexion weakness being most common. And this paper looked at those with the dorsiflexion weakness pre-op 6 weeks and 1 year. They showed that the most clinically significant improvement in weakness after undergoing surgery was sort of in that first 6 weeks. And then in 66% of the patients, there was no improvement beyond 6 weeks. So I think this is just important in terms of counseling patients on what their expectations should be, should they have a motor deficit. This paper was looking at for what is the optimal duration that we should make someone wait before doing surgery. Systematic review, 13 studies. It was cervical and lumbar, so 88% was cervical, 70% with lumbar radiculopathy. So most of these patients showed improvement within 4 weeks. And then sort of this paper looking at all these different studies so that sort of before or the time frame 4 to 8 weeks would be the optimal timing to undergo surgery. And then this is sort of consistent with the NAS recommendation. It's a little bit longer, obviously, but within 6 months to 1 year, the NAS guidelines say that it's associated with better recovery and long-term outcomes. So I did present the sport at our journal club, the sport trial, a couple of weeks ago. This is just the 10-year outcomes from the sport trial, which is really recent. It just came out, I think, 2021 or last year. So this was interesting, but again, there was the observational cohort and then the intent to treat cohort. So that observational cohort had primary outcomes in 3 months to 2 years. Those with surgery did better, and then no difference in the intent to treat group. Again, that intent to treat group had a crossover rate of 54%. So sort of hard to sort of draw any conclusions from them specifically. But then also they found that so that as treated, so those that underwent surgery sort of did better at 4 and 8 years. Again, a lot of this was sort of patient self-selection. So the patients that were sort of like older and were not as debilitated by their symptoms tended to not undergo surgery. And then younger patients were more debilitated by their symptoms, underwent surgery. I think the takeaway from this, though, is that patients who feel like they need surgery do better with surgery. In general, I sort of like working with athletes, like return to play or return to sport type papers. So this one I thought was nice. It's a sort of a younger cohort, so under 21, but basically retrospective review, do patients sort of, if they undergo microdisc, can they return to play at the current level or a higher level? So looked at high school and college kids, but basically there was no difference in return to play than those regardless of like Furman grade, level of herniation, and then if they were playing at college versus high school. And they had 71% return to play at the prior level, sort of within 5 months, and 96% at the same level or higher. So, this was nice. I feel like reassuring that this surgery is helpful to athletes. And then this is just the NAS guidelines, talking about, so based on the sport trials and some other trials, but basically, if you have lumbar disc herniation with radiculopathy, sort of medium to long-term outcomes are going to be better with surgery if their symptoms are severe enough to warrant surgery. And that's a grade recommendation of B. All right, in this paper, again, this is the main lumbar spine study, just looking at 10-year outcomes. So basically 69% of the surgical patients versus 61% of the non-surgical patients reported improvement in their predominantly leg and back symptoms. And 71% of surgical patients versus 56% of non-surgical patients were happy with their current status. Again, showing that surgery for patients that need surgery can be helpful. The other takeaway from this paper, though, was that there are still patients that have pretty significant disability at the 10-year time point, sort of regardless of treatment, just from the pathology itself. And then not to leave cervical out of this discussion, this paper looked at a prospective RCT, 81 patients, 3 groups. So surgery, collar, or PT, specifically with 15 visits. They looked at various time points. They looked at patient-reported outcome scores. Basically, at 1 year, sort of all of the, at 4 months, surgery did better than non-op. At 1 year, though, the outcomes were kind of similar. So the conclusions were pain intensity, muscle weakness, and sensory loss can be expected to improve within a few months after surgery. A slow improvement with conservative treatments and recurrent symptoms in the surgery group may take a year, but the results were about equal. And then this paper just also looked, this is an older paper, but this was a prospective multi-center study, non-randomized, but 503 patients, 49% with radiculopathy. They found that surgical patients had significant improvements in their ability to perform ADLs. But they did note the patients who underwent surgery still sort of rated their pain as persistent or excruciating at sort of the first follow-up visits, and then that tended to normalize after a couple of months. All right, so those surgery main points. So HMP in the cervical lumbar spine, typically self-limiting process that doesn't require surgery. So again, over 80% of cervical and 90% of lumbar herniations will sort of resolve within the first 6 weeks. So surgery in the short term may sort of decrease symptoms, but it does have associated risks. If considering surgery, it may be beneficial to proceed within the first 3 months, however, which is kind of like a sort of an interesting sort of tightrope to walk with the patients. You want them to wait a certain amount of time to see if a non-op can improve or the natural history can improve their symptoms. But at the same time, surgery a little bit sooner is associated with better outcomes. And that's it. So thank you to everyone. This is my last week. I really appreciate everyone at San Diego Spine has made a really great rotation. This is just been really great. So thank you, everyone.
Fantastic job. Thank you, Jasmine. A big topic to cover too, but I think hopefully really relevant to you and in your practice as well, and kind of understanding just how common this problem is. You know, I always tell a story of my wife and I, we both herniated within about a month of one another, and she's a mother of 4 kids, and you know, I have a busy practice, so she ended up saying, "There's no way on earth I can have surgery," and then I was like, "There's no way I can't have surgery because I can't work the way I am." So I ended up having a discectomy with East Black and Bruffy, and my wife ended up having injections. And I would say 2 years later, we were literally exactly the same. You know, I was doing what I wanted to do. She was doing what she wanted to do. I tell that story a lot to my patients. Just I just help them with understanding that give it enough time, these things usually get better. But anyways, just anecdotal. But thanks for a great talk.